Good evening, everyone. Uh, Today I'll be discussing a very interesting topic, newborn care, and I'll be talking about essential newborn care. We'll be discussing the definition components, how to provide ENC algorithms, and prevention of hypothermia in neonates. Uh, Firstly, the definition of ENC. Majority of the babies born healthy at the term and care during the first hours, days and week determine whether they remain healthy or not. And they have to be put on basic care to support survival and well-being. Includes care from birth till 28 days of life. That is the neonate period. Neonatal death under 5 year deaths were 37% in the world, whereas in India that was around 50%. But now because of the advances in NICU care, it has come down to 27.5%. Uh, Major causes of under 5 mortality are neonatal sepsis, pneumonia, and diarrhea. And now it has further come down. The sepsis has come down from 45 to 36%. Asphyxia has come out to be a major cause now, 23%. And diarrhea has gone down to 2% only. Uh, in India, when and why do neonates die? In India, the neonates die most in the initial first week. Thereafter, in fourth week, it comes down to 4.2%. And the cause of death is usually the sepsis, pneumonia, asphyxia, prematurity, and tetanus. There are four basic needs of newborn. That is, one is to breathe normally. Second is to be protected. Third is to be kept warm. And fourth is the feeding part. So, first, the interventions, clean childbirth and cord care that prevents newborn infections. There should be a thermal protection to prevent and manage newborn hypothermia. Early and exclusive breastfeeding, which is started within 1 hour of the birth. Initiation of the breathing and resuscitation. Early asphyxia identification and management plays a key role. Then comes the universal precautions and cleanliness, hand washing, gloves, protect yourself. We have to protect ourselves also from blood and body fluids, because many a times we have come across HCV positive babies also, HIV and HCV born. Uh, we have to protect ourselves from blood and blood products. Sharps and waste disposal should be adequate, and we have to deal with the contaminated laundry as well, and sterilize clean contaminated equipments. Hand washing essentially we should keep the baby in a cold free warm room where the temperature should be more than equal to 25 degrees Celsius, and use a clean dry warm delivery surface. Use a radiant heater. Two clean warm towels, clothes, dry wrap and cover the newborn baby is a must, and folded piece of clothes are also available. And preparing for the birth, we should have a suction device, newborn size, self-inflating bags, mask, laryngoscope, oxygen supply, disposable medication should be available properly. Care of the baby at the time of birth. Until around 1 hour after the birth, provide routine care at the birth for all newborns, and identify and manage newborns who may need special care. I'll be discussing in detail about those babies requiring special care. In routine care, call out time of the birth, because time and date is very important. And kangaroo mother care, we are all well aware of. That prevents hypothermia, and there is a bonding between child and a mother. Dry baby, wipe mouth, nose with a clean cloth. Assess breathing while drying. Clamp cord after 1 to 3 minutes. Cut with sterile instrument. Put sterile tie. And there may be bleeding from the cord because of the ligature slippage. So we have to take care while tying. Put identity label on the baby so that babies don't get exchanged where there is a high load of in the delivery room. So examine for malformation, congenital birth defects, and birth injuries. Initiate breastfeeding within 1 hour, record baby weight, give injection vitamin K 1 mg intramuscular, 0.5 is for the preterms, and cover head with cloth, cover mother and baby with warm cloth. And for the resuscitation, all babies must be assessed for need of resuscitation at birth. At least one person skilled in providing resuscitation must be present. Ventilation must be started within 1 minute of birth so as to prevent asphyxia and brain damage. First golden minute, resuscitation flow charts that depicts at the time of birth when we receive baby, there should be dry warm linen wrapped around the baby. Then we have to see whether the baby is crying or not, or breathing. If child is crying and breathing, routine care, dry baby on mother's abdomen, provide warmth, skin to skin care, and assure open airway if needed. Cut cord in 1 to 2 minutes. Ongoing evaluation of the neonate should continue. If child is not crying or breathing, cut cord immediately and place under radiant warmer. Provide initial steps, dry position, clean airway, tactile stimulus. If the child in 30 seconds, if the child is gasping and apnea or heart rate comes down below 100, then we have to, there is no labored breathing, there's no cyanosis, then we can continue with the routine care. If there is gasping and apnea, then we have to initiate positive pressure ventilation using air and oxygen. And with the positive pressure ventilation, heart rate after inflation should not be less than 100 beats per minute. If heart rate is above, then further evaluation, routine evaluation can continue. But if it is less than 100, then look for the chest rise. If not, reduce any leaks, ensure open airway, consider increasing pressure. If heart rate still goes down below 60 beats per minute and chest rising is less, continue positive pressure ventilation, add 100% oxygen, start chest compressions. And if heart rate is not detectable or is less than 60, then we have to give adrenaline at 0.01 to 0.03 mg per kg IV, or we can we can intubate the child and put adrenaline via the ET tube also, 0.05 to 0.01 mg per kg. Now, where do babies go from the delivery room? We have to refer the babies if the birth weight is less than 1.5 kilogram, or if it is less than, if it's a preterm baby. Major congenital malformations are to be looked for, which is, we have to look for surgical correctable birth defects or otherwise also. Severe birth injury should be checked. Respiratory distress, positive pressure ventilation for 1 minute, or needing chest compression or drugs, we have to refer them to NICU, neonatal ICU. Observation care, birth weight, if the birth weight is between 1.5 to 1.8 kgs, or intermittent positive pressure ventilation, less than 1 minute or vigorous. Now, immediate cord care, clamp or cut cord with the sterile instrument only, and use a sterile thread only, and or a sterile clamp. 2 to 3 centimeters above the base, because I have seen many times, being a surgeon, I have operated on so many babies whom there was umbilical hernia, and cord was and gut was clamped along with the cord. So you have to check for the umbilical hernia while clamping the cord, and by default you have to clamp the cord 2 to 3 centimeters from the base. Observe for any oozing or blood. Do not apply any substance on the stump. Do not bind or bandage the stump. Let it be open. Leave stump uncovered. Now, newborn can lose heat in 4 ways: radiation, convection, evaporation, and conduction. Now, keeping a newborn baby warm after delivery is utmost objective. We have to decrease the evaporation by drying the baby with a clean, warm, dry cloth. The conduction by kangaroo care. Put the baby on the mother's abdomen or on a warm surface. And the convention, we have to keep the room warm, draught-free room with more than equal to 25 degrees Celsius. Then radiation losses can be minimized by keeping the room warm. This is the typical picture which shows kangaroo mother care. This enhances bonding, increases lactation, and this keeps the baby warm, prevents hypothermia. And there's no need for a mother to do this kangaroo care. Any person in the family can do it if mother is undergoing a C-section or otherwise. So any family member can do it. So skin to skin contact, any family member can do it, not less than 1 hour at a time. And it is useful for especially low birth weight babies. And it provides warmth, promotes breastfeeding, protects from infection, emotional bonding is there, physiological stability which reduces apnea, and multimodal stimulation. Now, warm delivery room should be there, immediate drying, skin to skin contact at the birth, breastfeeding, bathing and weighing should be postponed because it can cause hypothermia and infection if it is done in hospital scenario. So it should be postponed. You can clean the baby properly using wipes. Appropriate clothing, and mother and baby together should be kept together, and warm incubators should be used for transport. Now, something about the breastfeeding. It should be initiated within first hour of the birth, and a trained nursing officer should or a junior resident or doctor should help mother at the first feed. We should ensure good position, good attachment, and effective suckling. So postnatal environment should be kept warm. There should be no draughts. Temperature should be more than equal to 25 degrees Celsius. Mother baby kept together in same bed, rooming in, which is called as rooming in. Bonding can respond quickly when the baby wants to feed, reduce breastfeeding difficulties. We should ask the mother, do you or baby have any problem? Has infant passed stools, urine? Have you started breastfeeding? Is there any difficulty in feeding? Do you have any pain while breastfeeding? Give any other food or drinks to the infant, which is being done by the relatives. So examine the baby, count breaths for 1 minute. It should be normally 40 to 60 breaths per minute. Sometimes it is 30 to 40. But look for severe chest indrawing. Look and listen for grunting. Look at the umbilicus. There is any redness, draining pus. If there is a feculent, rule out Michel's tuberculum. If it is watery, rule out patent urachus. Look for skin pustules, 10 or more pustules, or a big boil. Then auxiliary temperature can be taken, which is informative, lethargic. Check for lethargy, jaundice, and congenital malformation. Now, if not fed in previous hour, ask mother to breastfeed and observe for 4 minutes, and check whether she is able to attach. For attachment, chin should touch the breast of the baby, and mouth should be wide open, lower lip turned outwards, more areola above than below the mouth. Help mother to position, infant suckling effective, slow, deep sucks, and sometimes pausing. Not sucking well, ulcer or white patches in the mouth should be ruled out. Difficulty or painful feeding, then check for the mother's engrossed breast or breast abscess, flat or inverted, or sore nipples. Then Melia, Epstein pearls, Mongolian spots, enlarged breast, capillary nevi, they should be checked. and transitional stools, which usually occurs from meconium to takes 2 to 10 days for normal colored stools. That should be checked. Vaginal white discharge, bleeding due to maternal estrogen can be checked. Red rashes on the skin, 2 to 3 days of life can be checked. Weight loss, 6 to 8%, which is 10 to 12% in preterms. First few days of life should be checked. And skin and eye care, not bath routinely in hospital. Hypothermia infection should be checked, maybe. And child may be sponged with lukewarm water, and no routine eye care is required. But if there is a watering in the eye, then tobramycin can be used. Immunization, BCG, OPV, and hepatitis B is to be given at birth. Now follow-up, first week on day 3 and day 7 of the delivery, low birth weight, day 14, 21, and they should be called every weekly. And growth development and signs of illness should be checked, health education of the parents, and once every month for 3 months, and subsequently 3 months till 1 year should be called upon. Summary, basic care to support survival and well-being is essential newborn care, and ventilation must be initiated within first minute of life. Help to initiate breastfeeding with the first hour of the birth. Identify and refer neonates requiring special care, and prevent infection and hypothermia, and conceal mother for the danger sign, and immunization and follow-up. Thank you. I have to share one incident which has occurred recently. There was one child who was operated outside. Some gynecologist have operated on that child, and I got a call at night. I was not here. I've gone for a conference, so I've got a call that night saying that all the attendants of the child, they are against our life. They are saying that during the surgery, we have given an incision over the patient's abdomen, and we have opened in cesarean section, we have opened the abdomen, and all the gut are lying outside. So this is a common mistake, because we usually get the radiology people, all the doctors who are doing ultrasound, they have not picked up any gastroschisis or omphalocele. Actually, that was a child with gastroschisis. So they have not ruled out gastroschisis, and that doctor's hospital, all the glasses were shattered, and all the attendants were sitting outside the AIIMS main road. We're going to block that road, and it was a big mess, because the radiologist didn't pick out gastroschisis, and it was all the blame came on the gynecologist who has operated and done cesarean section. And I tried to convince the attendants, and somehow we managed to and we informed them well that that is a congenital anomaly, that is not caused by a gynecologist, that is just mere a congenital anomaly which can be corrected. We can operate on it and it can be corrected. It is not the blade of the gynecologist which has done all the abdomen, there's an incision over the abdomen and all the gut are lying outside. So this is we should get proper ultrasound before treating such cases, because if radiologist has missed that point, then all the blame comes on the gynecologist. So that the take-home message is we should thoroughly investigate the child before taking any surgical procedure. And thank you.
Thank you, Dr. Navdeep, for a great talk. In fact, newborns care is the most important